Well, thank you to the moderators and to SAGES for inviting me to be part of the master's group. When I look at the folks up on the podium with me today, these are really people that inspired me to go into foregut surgery. And in fact, if you notice, both Dr. Potty and I are wearing bow ties, so I picked that up from him over the years. I do have a minor disclosure. It shouldn't affect anything I'm talking about today. But I do have a disclosure that I am trying to, through the Communications Committee of SAGES, enhance our social media presence and really take the conversation out of a person at a podium talking to the audience and make it really more of a dialogue. So 2 ways to do that. One is through Twitter, and if you go on the app, you can participate using the SAGES 2017 hashtag, and then also the Facebook group that Dr. Olschlager started talking about. Just to briefly show you, it is a closed Facebook group, so it's only open to surgeons. It's a place to place comments, to ask questions. When people talk about what are the technical steps for a perfect fundoplication, like Dr. Potty was talking about, this is really a way to discuss those questions. The Facebook group as of last night had almost 700 members in 44 states and 40 countries on every continent except for Antarctica. So just as an example, and to tie this into the topic of my talk today, this is a surgeon that posted a case. The patient had cough and had reflux and epigastric pain, but some of the things didn't really add up, so we posted the endoscopy, the manometry. Within 24 hours, 17 comments, including people asking to see the upper GI, which was then posted, and people can actually include videos on the page so that we can actually watch surgical videos or endoscopic videos, and then discussion of the literature, and even then affecting the patient's care plan as the physician modified their treatment. So it's really powerful and profound platform, and I would invite all of you to try to join the group. So now to go ahead with the real topic of this discussion, which is really reflux in both pulmonary and laryngeal disease. When I started thinking about this, I didn't really want to just throw up a bunch of literature and a bunch of slides. So I really want to tie this into some of the clinical scenarios that we see in the clinic day in and day out. So I'm going to really talk about a story in three patients, one of IPF, one of lung transplant, and one of cough. All of these three are real patients that I've seen within the last month in my clinic. So let's start with IPF, and Dr. Potty mentioned this briefly. Idiopathic pulmonary fibrosis is actually a rapidly increasing diagnosis. And this patient's a 70-year-old retired gentleman, otherwise healthy, was playing golf. He started to notice he couldn't walk the course anymore. He started to have to get in the golf cart to drive around. So he came in and was evaluated and found to have idiopathic pulmonary fibrosis. At that point, really minimal reflux symptoms. He took a PPI a couple of days a month, but really well controlled. Had never thought about anti-reflux surgery in the past. Well, what do we know about IPF and GERD? Well, IPF is progressive fibrosis of the lungs. It is of idiopathic nature, meaning we don't really know what causes it, except that there's a growing recognition that there's probably at least a link, if not a causation, between GERD and reflux. And it's thought to be contributed to by chronic microaspirations. Oftentimes these patients are actually asymptomatic from a GERD perspective. They may be having silent reflux. And there are some data that suggest that it may be pepsin-mediated, so non-acid reflux may actually be more important, and that leads some flavor to the discussion of whether to treat this medically or surgically. The 5-year survival is pretty dismal with IPF. This is a Kaplan-Meier survival curve. On the left, you can see in the dark line, this is a Kaplan-Meier survival curve for all comers with IPF. Interestingly, patients with IPF treated with antacid medications, typically PPIs, have a better survival curve. On the right of the screen, it shows patients with IPF who've had a Nissen fundoplication. You can see they also have a survival advantage, and although there's not really a comparison between these groups, if you're a surgeon, this looks to me like they have better survival in the Nissen group. The link between GERD and IPF has now penetrated the pulmonology world, and their guidelines now suggest treatment of reflux in patients with IPF, although the level of evidence is still considered small, and there's a lot of controversy about how to treat reflux in these patients. And there's been some doubt thrown on this recently. This was a fairly recent paper that showed in a large pooled analysis no difference in survival between patients with IPF treated with PPIs versus those that weren't. And interestingly, the patients put on PPIs had a higher rate of pulmonary infection. So now there's a little bit of a backlash to PPIs in this world, saying maybe the PPIs actually aren't the right treatment for IPF. And I think that brings us back to the idea of surgical treatment. So what do we do at the UW? Well, all patients who come into the pulmonary clinic with IPF get esophageal testing, and that's regardless of symptoms. And that is because of that prevalence of silent reflux. Typically, we're doing 48-hour Bravo studies and then manometry regardless of their symptoms. And the pulmonologists have a slight preference for surgical treatments over PPIs, although that continues to be an active part of discussion. Our group recently published our early experience with this patient population. So this was about 40 patients with IPF and GERD. 14 of those patients were pre-transplant and actually went on to lung transplantation. I think it's important to note we had no intraoperative complications and no 90-day mortality. And the reason that's relevant, these tend to be pretty sick patients, often on oxygen, often pretty frail and debilitated. So to be able to go back to the pulmonologist and show that we can do this safely, I think goes a long way to establishing credibility. Length of stay is quite reasonable. We do these laparoscopically. The median length of stay was 2 days, about a day longer than normal, mostly because of the home oxygen issues. So this is not a Kaplan-Meier curve. This is a cumulative mortality curve, so this goes up instead of down. But you can see in this patient population at 5 years about a 50% mortality, which in most disease you think 50% mortality is pretty poor, but actually in IPF that's quite good. So we're pretty pleased with that. IPF function is measured by forced vital capacity, or FVC, and you expect a steady progressive decline in IPF. So these are patients who underwent fundoplication, and you can see there's still a few patients that have that progressive steady decline, but we actually have other patients who had an increase in FVC after surgery, and the red line being the mean, you can see that actually it's a pretty flat curve, which is, again, quite good for this population. I don't mean to speak only about IPF, and certainly GERD is linked with worse prognosis in a lot of other pulmonary diseases, including COPD, asthma, cystic fibrosis, and other non-IPF fibrotic or interstitial lung disease. So we are actually in the midst of a multi-center randomized controlled trial, the WRAP-IPF study, in which patients are being randomized to surgical versus medical treatment. And we've completed enrollment of patients, but we don't have the long-term data to present for that yet. So going back to the case, this is a patient, 70-year-old male with IPF, relatively early in his disease course with minimal symptoms but documented reflux. We brought him back. We did our testing. He had mild dysmotility. He had a positive pH study with a demister in the 30s and an upper GI and endoscopy showing a small hiatal hernia. So we did a laparoscopic tooth-pay fundoplication, and I just recently saw him for his 3-month follow-up. His demister score is normalized, and importantly, his pulmonary function tests have not changed. They have not declined as one would expect in this disease process. So moving on to case number 2, this is lung transplantation. So this is a 55-year-old guy with ILD due to I can't even pronounce it, synthetase syndrome, which I'd never heard of before I'd met this patient. But presumably there's a reason for his pulmonary disease other than GERD. So the question is, does GERD contribute to his pulmonary issues? He did present with some mild GI symptoms, primarily of dysphagia, and his pulmonologist had actually put him on PPIs for the last 5 years and had no change in his GI symptoms over that time. And he was listed for lung transplant. So what do we know about GERD and lung transplantation? Well, lung transplant patients have a median survival of about, or a 5-year survival of about 55%. 3/4 of lung transplant patients have reflux. And one of the primary causes for lung transplant dysfunction, bronchiolitis obliterans, is not due to rejection and may be mediated by GERD. It's typically a fibrotic disease that does not improve with immunosuppression. And again, just like with IPF, there is some evidence that pepsin may mediate this phenomenon. So this is research out of Pittsburgh in their transplant and cardiothoracic group, looking at the effect of fundoplication in their lung transplant population. So this first graph shows patients who received anti-reflux surgery before transplant, and you can see that if they receive anti-reflux surgery, their FEV1 actually improves. And similarly, let me go back one here. Similarly, this is their graph in patients who received anti-reflux surgery after lung transplantation, again showing an improvement in FEV1 after fundoplication. So you take this patient, same patient, ILD and this unusual syndrome with some mild GI symptoms. He comes in pre-transplant and we test him, and that's part of our transplant protocols. They all get tested for reflux. He had slight dysmotility. He had no hiatal hernia, some mild dysmotility in his upper GI, but his Demeester score is only 8.6, so he had a normal Demeester score. So in this patient, we did not perform anti-reflux surgery. We actually took him off his PPIs. He went on to receive a single lung transplant, and about 6 months after his transplant, he came back for repeat physiology testing. So here he is post-lung transplant, again, some mild dysmotility, but now he is positive on his pH test. His Demeester score is now in the high 20s, or 24, but with poor symptom correlation. And his upper GI shows the slight dysmotility with escape of the swallowing contents. So I just by raise of hand, I want people to raise their hands if you think, would you put this patient on PPIs? Smattering of folks. Who would do a Nissen? Another smattering. How about a toupee? A few more people with a toupee. How about something else? Lynx, something? All right, nobody wants to do something else. So we did a toupee, and he came back for his short-term follow-up. He's doing relatively well. His dysphagia symptoms actually worsened, and so this is his upper GI from about 2 weeks after surgery with slightly increased dysphagia. That actually then subsequently got better. I don't have his follow-up PFTs because he's so fresh from surgery. So case number 3, here's a 43-year-old male, had a Nissen fundoplication in 2001. He comes into clinic. He has about 3 months of cough and some increasing regurgitation and dysphagia. And he is worried. He came to me specifically because he was worried that he had recurrent reflux triggering his cough. And in fact, if you go back to his fundoplication in 2001, the rationale for that surgery was for chronic cough. So he comes in convinced that he has reflux causing cough. Well, what do we know about cough and GERD? First of all, cough is a very common complaint, and GERD is a very common complaint. So you see a lot of patients with a combination of cough and GERD. There are some chest guidelines looking at chronic cough in GERD patients. I think the most important take-home point from this slide is that there's a very strong placebo effect in patients with cough. 88% of patients with cough resolve within 3 months, but it may take a long time for them to get better, so it often takes months. Interestingly, in a number of studies, lifestyle modifications are better than PPIs for cough, and PPIs in isolation have been shown not to affect cough resolution. The chest guidelines call for esophageal testing only if symptoms last more than 3 months and only if patients are being considered for surgical treatment. And if they have a negative pH test, that has a 100% negative predictive value for anti-reflux surgery. So if they have normal pH testing, they will not benefit from anti-reflux surgery. Well, what can we say about, so that's cough and GERD. What about cough and anti-reflux surgery? So this is data from our own group that was looking at respiratory and other symptoms following anti-reflux surgery. So this is cough. And you can see that about 75%, about 3/4 of patients improve after reflux surgery, and about 40% resolve. Similar data for hoarseness. Again, a moderate amount improving and a moderate amount resolving, and also for wheezing. So you put these things together, and I think you can say that these symptoms do improve after anti-reflux surgery, but probably not to the degree that typical symptoms like heartburn and regurgitation will improve. And I think it's also interesting that the relative rate of improvement is pretty similar to the relative rate of improvement that we see with placebo effect. So take that for what it is. So this patient comes in, again, he has recurrent symptoms of dysphagia, regurgitation, and cough. So we put him through the standard workup. His manometry shows some dysmotility. That's a recurring theme today. His upper GI showed some intraesophageal reflux, but no gastroesophageal reflux, and he had a normal RAP on his upper endoscopy. Demeester score is 1.2. So here's a patient who comes in absolutely convinced that his cough is due to reflux, and yet he doesn't have objective findings of reflux on his physiology testing. He didn't actually like me at first when I told him I didn't think surgery would help him for his cough. And this really shows the importance of a good collaboration with ENT colleagues. So I did send him to ENT. He actually had unilateral vocal cord paralysis. They started him on gabapentin. They started him on speech therapy. Complete resolution of his cough in 3 months. He came back in to see me a couple weeks ago because he says, my cough is great, but I'm still having this terrible regurgitation. And I actually think that his issue is not gastroesophageal reflux. He's actually having intraesophageal reflux because of poor motility and the Nissen fundoplication. So he's on my schedule for next week to do a takedown to a toupee. We'll see how that affects his symptoms. So I wanted to use these 3 cases just to illustrate some sort of thinking about these atypical symptoms in GERD. So the IPF patients, I think clearly there's mounting evidence for this, and hopefully our multi-center randomized controlled trial will be out soon. I think lung transplant, there's pretty good consensus that they should be at least evaluated for reflux, although still some controversy about medical versus surgical therapy of reflux. And I think with the atypical symptoms, cough, I will still operate on selected patients for this, patients who have a good story, who have evidence of, say, laryngeal edema on their video laryngoscopy, and who have positive pH testing. But I think you have to be really careful in your preoperative discussions and evaluations of these patients. So just a couple take-home points. 1, I think anti-reflux surgery is generally underutilized in pulmonary disease. 2, I think transplant patients not only need to be tested pre-transplant, even if their testing is negative, they need to be retested post-transplant. And 3, reflux is really a multidisciplinary disease. It's not just GI docs, it's not just surgeons, but really involving pulmonary and ENT in the discussion for these atypical patients is critical. And then the last thing is the patient selection and informed consent are really key to success. Thank you very much.
If I can emphasize one thing while you step into the mic on what Dr. Wright just said, especially the otolaryngologist, but I think the pulmonologist as well, I would give a little bit of a warning. I think that what you said is key and critical, but there is a difference between your run-of-the-mill otolaryngologist and someone who really has an interest in the larynx, in these speech and cough and other issues. The average ENT, I hate to generalize, is going to look at a patient, and anything that's red, they're just going to, most of them will say that's reflux, and then send them to you or someone else, and they'll end up in your office. I don't put a lot of stock, frankly, in most otolaryngology evaluations. I don't know if you have any thoughts or comments on that further.
Yeah, no, I can't agree with that more. So I think that's absolutely spot on.
Hi, Mike Wood, Dartmouth Hitchcock. I just had a quick question on that last patient you were talking about, that you're going to try to convert his 360-degree Nissen to a toupee. And I just wanted to ask you, did you ever consider doing a dilatation, or would you not do that for the Nissens anymore to see how he does, or why go right to a toupee?
No, that's a great question. And honestly, for the interest of time, I compressed things a little bit. So he's actually had dilations and hasn't improved. And that's actually part of that conversation with him. The fact that he failed to improve with dilations, I think, is a little bit of a negative predictor for response to conversion. That being said, he's so desperate that I'm willing to take that on with him as a partnership, knowing that we're unsure of the results.
Hi, Haas Jassim, Green Bay, Wisconsin. Do you guys have, do you guys use ResTech in your algorithm of workup? And if so, how do you implement that as far as, the findings with the ResTech? Do you ever see, say, an equivocal Bravo study, but maybe a positive ResTech, and they've got pretty classic LPR symptoms, and how do you implicate that?
Yeah, we don't do ResTech in our own motility lab, and we do run our own motility lab, but we'll occasionally see patients referred from elsewhere who've had the ResTech study. I frankly don't know what to make of it yet. The folks that have a positive pH test and a positive ResTech, I'll believe that, but the patient who has a negative pH, negative Bravo, negative standard pH test, and a positive ResTech, I'm hard-pressed to operate on those patients. Just because I don't know that I rely on that yet.
Great presentation, and thank you for bringing this patient population to light. I think this is a largely unrecognized and underappreciated patient population, especially in terms of the consequences of their reflux. And I think this is going to make this gap that we're talking about larger as these patients come forward. I'm curious about your use of partial fundoplication in these patients. I think the first one you showed, you used a partial fundoplication, but I don't recall there was underlying esophageal motor abnormality. And can you comment about use of that in these patients where absolute reflux control is probably more important than maybe different patient populations?
Yeah, I mean, that's certainly a big topic of conversation. And interestingly, so a few years ago at SAGES, there was a Nissen versus Toupet debate, and I was assigned the pro-Nissen topic. And in writing that talk, I actually changed my mind, and I'd become more liberal in doing toupees. So, but I think we could argue about that for a long time. I think most of the data in favor of non-selective, use Nissen in everybody, it's good data, but probably a higher dysphagia rate. Most of the European randomized controlled studies, as Dr. Potty shows pretty equivalent reflux control between Toupet and Nissen. So I've become more liberal. Just by happenstance, all of these patients actually did have dysmotility. I would still say it's 20% of my practice I'll do a Toupet. So it's not the majority, but it is a substantial minority. But yeah, you can argue selective versus non-selective. That's a whole other topic. Sure, I'll read this question. So this is a question from the app, it looks like. How will those terminally ill pulmonary patients tolerate general anesthesia for an anti-reflux operation? I think that's a good question, and that's why I think it was important in our study that showed that there were good and really no perioperative morbidity or mortality. Now, those are selected patients. The patients that we don't think are going to tolerate a general anesthesia, we're not operating on. So it's a very careful discussion with our anesthesia colleagues. We have actually a medicine consultation service that we use liberally. So that's really that multidisciplinary component. In the lung transplant population, whether we do an anti-reflux procedure before or after the transplant often comes down to whether we think they would tolerate an elective operation depending on their lung status before transplantation.
Thanks, all right. This is Akshay from UNMC, one of the fellows. Great talk, thanks. And as an inspiring talk, we read our own HRMs and high-resolution manometries. And, it's never black and white. There is a huge scale. At your level, what do you think, what actually you decide that this patient is going to go for Nissen versus Toupet? I see a lot of Toupets that you're doing. Like, what are your parameters that at your level that you decide based on the HRMs?
Yeah, so the question was about high-resolution manometry and how we use that to guide. I think the most important thing is to look at the studies yourself. And if you just take the study out of the printer without modifying it, without reading it, without understanding it, it's like the EKG machine read is wrong if you don't over-read it yourself. Same with manometry. You have to look at it yourself and really try to understand those nuances. So taking the time to learn how to read your own manometries, and even if I don't sit there and change the boxes, I look at the pictures and I get a gestalt for what things look like.
So do you have a specific, like a parameter, like a distal amplitude or DCI that you decide this patient's going for a Nissen or a Toupet?
Yeah, so I'm a data nerd, and I would love to give you the data and tell you there's a hard cutoff and a soft cut, but no, it's an individualized discussion, and a lot actually has to do with their symptoms more than their numbers. So treat the patient, not the numbers.
All right, thanks,
Great,
Andy.
thank you very much.